Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this next video, Professor Ben Tsui from the Stanford University School of Medicine in California is going to share with us his experience and insights into point-of-care ultrasound of the airway. In case you like any of our videos, do remember to like and share it with your friends. If you are new to this channel, then do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
So I want to talk to you about today is the airway ultrasound. So my disclosure is mostly is a publication that maybe relay some of the picture taking from it, particularly with the principle airway. Actually, we published this in 2011. In that book, I already quite put in a few the early study that we did using the ultrasound for airway. Now, today I just want to touch base on the airway ultrasound. Have been there for a while, like since we have the point of care ultrasound starting, ultrasound of the airway already has started. But today I just want to focus on the mirror of the ultrasound. A few things I think we have to be clear is five questions I want to try to answer for our audience today. Ultrasound can visualize the airway completely? Now it's quite interesting. We know the ultrasound, air is the enemy of the ultrasound. We'll see how much we can see with the ultrasound when we look at the airway. Now, obviously, every anesthesiologist's primary concern is, can we predict a difficult airway? Can we, in case of we in trouble, can we actually help, this ultrasound can help secure this surgical airway? And obviously, most of us also quite interested in regional anesthesia, particularly with the ultrasound, can we actually perform some of the regional anesthesia block to help us to do difficult airway, localize the airway so that we can do a fiber optic intubation. And last, I want to touch base on can we using the ultrasound to confirm access or actually guiding putting endotracheal tube. Now, I just want to point out that one of the most recent articles come out from Journal of Ultrasound Medicine, just published not long ago. It reviewed a lot of different ways to look at the airway, from look at the oral cavity to hyoid bone and trachea. Majority we will go for it, but I will highlight the most practical one for anesthesiologists. Now, first we look at, to answer the question, can ultrasound visualize the airway completely? When I first doing the ultrasound airway, sometimes we have so-called like high hope to get ultrasound can ultrasound everything. But one thing we have to remember, airway, within the airway is, we call it airway because it's containing the column is air. Now, we all know the ultrasound cannot penetrate air well, only can penetrate soft tissue, or that's why we need the gel. Anything missing in between air, basically the ultrasound get substantially reduced, the energy cannot passing through. Now, if you look at principle, basically, if you scanning from anterior to posterior, first thing you can see, likelihood, by looking at this anatomy, likelihood you can see the hyoid bone, because we can see reflection. So basically, we can see the outline of the hyoid bone well. Another piece potential we can see is the vocal cord, because from the thyroid cartilage, the vocal cord continues to the back structure. Now, anything in between, probably you won't be able to see much. What you see in front is just the barrier on here. And anterior to it, you can see the soft tissue. Anything behind this is just so-called the air tissue artifact. So anything you see behind is not the true structure a lot of people make mistake thinking that when you have a white line in between, there's a new membrane you're looking at. It's actually just the air tissue interface. Now, how we do the airway ultrasound? Now, obviously, quickly when you try to actually doing it, you already quickly find it's really hard to do it because it's irregular shape, poor contact area. So sometimes it's really hard to do. So when I first started doing is one thing you have to do is put a lot of gel. Or what we did at the beginning when we're doing study, we basically make a transparent gel pad to put on it so that we can actually maintain the good contact and try to avoid all the air in between so that we can see a good picture and then the ultrasound can penetrate through. Now using this, we look at different cadaver, look at see now, just like before we say that you can see the hyoid bone quite well defined. Behind the white bone, you don't see much behind it. Same thing is the live and cadaver. Now, if you move down to the second part, you can see the vocal cord. Now, some people think that, okay, we can actually using see the vocal cord and so forth, you can assess the vocal cord movement or tube size, or judging if the patient have too much edema, is it safe to extubation. But from my experience, sometimes it's challenging because a lot of things you cannot see. So sometimes you don't see, is it because of the you're not scanning properly, or actually the structure is there. So I think sometimes it's much harder to predict exactly. But for anesthesiologists, most of the time, once you secure the airway, I think you already put the endotracheal tube there, so you're not assessing the how they are talking. But the ENT actually have been looking at this to see any vocal cord paralysis and so forth. So for our intensive purpose for anesthesiologists, this modality is very seldom using in the OR. Now, one thing that we get a lot of interest is a so-called look at the cricoid cartilage, because we know one of the difficult area algorithm at the end, we're trying to find the cricoid membrane and put the percutaneous, put the needle so that you can do jet ventilation or dilate it to change to trach in this aspect. But for this one, actually, if you look at it, it's quite interesting in a way that if you look at this area, you can see that it's open area. So it's almost like half open donut, but once you scan more cardiac, become closed. So this is a distinct way, easier way to do, to find the cricoid membrane. Now, one thing is, as I mentioned, anything behind this line is all artifacts. So it's not truly have a structure behind you can see both sides. So that's the important thing to know of. But we'll discuss how this actually been useful when we're doing the, trying to find the, do the cricoid membrane percutaneously. Now, when you look at the longitudinal views, it's also quite beautiful that you can see the chyloid cartilage and the tracheal ring and so forth. So you look like that, oh, with this one, we should able to do the secure the airway surgically, put the needle through in between safely, etc. But actually, in reality, it's not that straightforward. We're going to talk about it next. So before we go that, before you get in trouble to need a surgical airway, so first when you look at, can we actually predict difficult airway? Now, when you think back on the difficult airway, we look at the classic way, beside the malpractice score, we look at how big the mouth can open, thyroid, mental distance, etc., so forth. So in theory, that you should able to ultrasound out exteriorly. And actually, when I first started, say, in addition to ultrasound exterior to look at the structure like the previous slide, potentially we can actually do sublingually, but this is from outside. You can see the ring and so forth. Potentially you can measure distance and calculate the distance, etc. But actually, you can actually put the ultrasound probe under the tongue, actually you can measure the distance between the distance to predict measure the hyoid bone distance to predict maybe a difficult airway. So we performed this with an early study and we published that. But actually, we find the sublingual ultrasound actually is much better predictor, where even just by measuring outside or Mann-Press score. But one thing we realized that one thing is with the more and more different airway device we have to rethink about what we mean by difficult airway. Traditionally, the measurement or the ultrasound we just perform, it just predict maybe difficult with traditional way to do a laryngoscopy. But nowadays we have so many things like CMAC, video scope, and so forth. So it changed the dynamic. So it used to be difficult airway when you have the guide scope or CMAC, make it easy. And nowadays we have different the fiber optic light one type picture that you actually can do this and have a camera in between, and also you can bend and so forth. So I would say it's much harder to predict using one ultrasound to predict difficult airway for all the different tubes. So that become more challenging to see, because a lot of airway problem already solved by different video scope by and large. So, okay, so if not sure, most of the time you can bail out with the video scope. What happens if you really need a surgical airway? Particularly is cricothyroidotomy. Now, actually, that like about 10 years ago, that from UK already do a study. Basically, what they say when you have cannot intubate, cannot ventilate, and 65% when and it is trying to secure the airway by putting needle through fibroclinical membrane. 65% is fail. It's really high failure rate. But we looked at why is it. Now, as I mentioned, that we have beautiful picture we can see, but the thing is, just like when we first start doing ultrasound for regional block, sometimes you get a good image, doesn't mean that you can put the needle through. Now, for example, that because when you put the ultrasound probe, you need already mentioned, need a lot of gel, and your ultrasound probe will be cover your the needle entry point, and it's so meticulous, small area to go through. It's almost like trying to do the thoracic epidural directly guided with the ultrasound. Same problem again. So as I mentioned, that it looked like easy. You get a good image, you know where's the cricoid cartilage, and you see the gap in between. But how to guide is difficult. Why? Because as I mentioned, that all the picture we produce is calm, elective situation. We put lots of gel, a lot of gel pad, etc. So when you're in emergency situation, do we actually have time to do it? Should we do it out of plane or in plane? It's really hard to do. So what we have learned from this, actually when I try to do this, actually it's not that straightforward. Just like how we do the ultrasound guided regional. First thing, you are challenging to get a good ultrasound image. And then we still have to put the needle through or your device through. So tactile feeling is difficult, and then you almost need a two-hand, because one hand has to stabilize the airway. Otherwise, when you push the needle through, the trachea will just slide away from you. And also, the other hand still have to like try to maintain, get the loss of resistance or aspirate any air when you insert into it. So basically, your two hands tied, and you need a third hand. Where are you going to put it? You can see there's no area to do it. So in theory, it can see the structure, but it's hard to guide the needle to it. I think another more important thing is we lack of practice doing this technique. Because I'm sure most of anesthesia very seldom have to resort to the surgical airway. So it's almost like the first time you do intubation, I'm sure we remember the first time when we do intubation, half the time doesn't work. Now we look back and say, how come a medical student have trouble getting so easy airway? That's exactly, we don't have enough practice on this. But I think later on, we just mentioned how we're going to create opportunity to increase the experience. Now, sometimes that when we have ultrasound, doesn't mean we have to abandon everything we have. Like sometimes I still using nurse stimulation when we're doing the deep lumbar praxis block or deep sciatic block. Some of our tools still can use it. I want to point out this one, actually, I find is quite useful, particularly not only in triggering toys we use, but basically using the physiology or physics of our body. We mentioned that ultrasound, the air is the enemy of ultrasound, but the air also can help us to localize the area we want to enter, because if the needle is like when we do nurse stimulation, if our needle just accidentally pop into the airway, there's become a disconnection. And actually, most nurse stimulator will keep changing tone or changing light from it. Actually, I did a study on it, and actually quite useful in a way. Now, in this small study, what we did is basically we put a fiber optic in the cadaver, this insulated needle. We're going to see when we enter, touching the skin, basically make a connection. And when it pops into the airway, you can see in here changing tone. So it actually can guide you. Using this method, basically, you don't need a third hand to do it. Now you can hear that changing tone. When you see pop through into air, it's changing tone. Then, and actually, if you look at nurse stimulator, most nurse stimulator will changing from green to red. You see, touching the back, it will changing. So to tell you that your needle is too far in. So using this method, basically we have a group of residents perform it, and basically the sensitivity with this one is 100%. So what we're using is, and actually we're using this for in the ICU to place the diet to do the percutaneous tracheostomy. But obviously, in this case, a control situation, we have the fiber optic in place in a real patient, and then we just pop it, but you can still hear the same philosophy that when the needle popping in, changing tone. To confirm it. And touching the side with changing tone again. So we tell you if your needle too lateral or the back wall. Now I want to point to you that actually we're using this for actually the give the transtracheal injection in a patient on the C collar. The main reason I show you basically concept the same. Basically, you hear that.
Organized, but just put a little bit of local just okay, little poke here. That's good. So as soon as I say yes, I want you to inject nice and quick, okay? So see the sound, changing sound? Yeah. I'll say where. So see the change in tone. Now inject very quickly as fast as you can.
Now you can see once you inject, because it conduct the whole system become conductive again, so it changed back to conduction. Now the reason I want to show this one is actually one of the way to increase your experience on putting needle for a cricoid for difficult airway. One, you can effectively topicalize the airway for your fiber optic intubation. Second, you already know where you should go. And sometimes what I do also using leave angiocath here so that I can do fiber optic, the retrograde, put a guide wire if you have to, but most of the time you already know where to go. So that if you get in trouble, your surgical colleague can easily, or yourself can easily convert that to percutaneous coagulotomy on it. So that increase your comfort level and how to find the location. So although this is not particular using ultrasound to do regional block, but actually using stimulation, you still can do that. But the question is, can we actually helping to using ultrasound to do regional block, particularly for airway? Remember with David Brown atlas, we can actually block the superior laryngeal nerve block by holding on the hyoid bone and then just touching bone and just walk off to it. But obviously in this case that we already know that we can see the hyoid bone. Basically, we put the in cadaver, we just demonstrate touching on it, just walk off, you can inject fluid too. So that technically you can do it. But most of the time now, if I need to do a topicalization, sometimes I rather to gain some experience on the doing transtracheal injection, get a good topicalization, and actually already identify the location so that you can quickly convert to rescue surgical airway much more secure when you already identify location. Last thing I want to touch on is the using ultrasound, can we assess or confirm your airway placement? Now, one thing is some people in the gym when they first start doing the ultrasound guide, I thought if somehow we can actually using ultrasound actually have a real-time guide our endotracheal tube into airway, that would be great. But technically or physically, it's not possible because you cannot scan somewhere in between the between your endotracheal tube, your air, so you won't able to see the picture. But on the other hand, actually, when we trying to do so-called ultrasound guided intubation, this will have if sometimes you can see that, but still quite useful situation. Can everyone see that? In other words, actually, it can tell you in the wrong place that when you intubate, you see one more time here. So basically, when you have training to intubate, you don't have to keep looking at on front. You can just put on the at that coagular level, tracheal level. You can see if you go into the wrong place, you see it popping out. So in other words, I will say we can successfully using ultrasound guided software intubation. Sometimes it's still quite useful. We can guide your NG tube in the right place, temperature probe. So you can put the temperature probe, you can actually see it too. So in a way that indirectly it can tell you your tube is in the wrong place. And finally, by itself, airway, I do pediatric. One of the pediatric population is we sometimes, because the margin area is quite small, quite easy you can get into right main stem, or sometimes when we need to do the lung isolation, how we're going to use the ultrasound to do it. So I just want to supplement the put the ultrasound plus some of the lungs ultrasound actually can help us to determine is the depth of the lung is ventilating. We already talked about it a bit early on with the lung sliding, but I just want to add on the diaphragm movement actually will more definitive to do it. Now the traditional one thing is sometimes people tell me, oh, they have a lung sliding, but it's hard to tell is actually ventilating if you're actually looking at the dislocation. But dislocation is principal need to use this is trying to determine is a pneumothorax, any air in between. But if you want to see the actual lung movement and ventilation, we have to be more looking at the side, also the position of the lung, so that so when we see the lung sliding down and open up. But traditionally, this way is difficult. So what we've been doing is a so-called intercostal method to do it. So basically, if you if the lung is ventilating, you can see it's almost like curtain side, but we're using the linear probe so that we focus on to seeing the lung movement. This side is so after interscaling, that side doesn't move. This method actually quite easy to do and quite useful, particularly when I want to actually confirm, make sure when I do the pediatrics, when we're doing the lung isolation, make sure that one side is not moving. Just show you actually quick video clip to walk out the step, also called ABCD.
Place the probe at the anterior axillary line. Watch for patient breathing and lung sliding on ultrasound. Move the probe caudal until the ultrasound monitor displays the lung pleura sliding into the zone of lung apposition where the diaphragm can be seen. Examine and note diaphragmatic movement.
So in a normal ventilating patient that take a breath, the diaphragm will contract and will get a figure. But obviously when you are already paralyzed intubation, you just see the lung sliding and the diaphragm remain the same size and move up and down. So in summary, just recap what we say. Ultrasound cannot see the airway completely. That's why we still cannot do the so-called real-time guided ultrasound airway intubation. Can ultrasound predict difficult airway? I think now with these questionable, in a way, you can predict maybe difficult to using laryngoscopy, but a lot of the airway issue already resolved by the video scope. And I think ultrasound will be really hard to predict which one even the video scope cannot handle it. Can ultrasound help secure the surgical airway? In certain extent, almost, but it can help to market the location prior to the get into emergency situation. But I have some doubt that when you see an emergency situation, it's really hard to do because the ultrasound is where you can see the good airway location or the coicofiber membrane location, but really hard to guide the needle into it because the probe is in your way. Definitely can help doing broad, particularly superior laryngeal nerve block. In terms of assessment, actually, this is one of the one I'm using the most in clinical practice is combined with lung sliding or diaphragm movement to judging where's my tube. Is it for lung isolation? Am I in the right place quickly? And also, am I ventilated the both sides instead of listening to the using stethoscope? Thank you for your attention. I'm more than happy if any question.